Let's raise awareness about nursing. What do nurses do? A lot of people don't even know. I find that when I talk to people, they think nursing is passing meds and listening to blood pressures. And that is probably the least accurate thing I've ever heard about nursing. Just to kind of put in perspective, there's a reason nurses are the top respected healthcare profession, or the top respected profession, excuse me, in the country many years in a row. And there's another reason nurses get paid as much as they do. Nursing pays really well. And the reason I say that is because we want more nurses. Now, you should never do it for the money because you will absolutely hate it. But don't feel that nursing is going to take you away from a work-life balance, because it doesn't. You have the ability, because of how the schedule works, we work 3 12-hour shifts typically, to be able to have a lot of days off in a row, to go out and do fun things with your family, with your friends, and also get errands done, and also make money where you're not feeling like you're living paycheck to paycheck. So nursing is a great field to get into. Nursing is rewarding. We work with people who are at the beginning of life. We welcome people into the world, and we welcome people to their next life. We see people pass away. We see people born. We see people get better. We see people get worse. Nursing is so rewarding because you get to see your compassion and empathy, your advocating spirit better someone's life. Nurses are advocates. They're patient advocates, meaning we fight for our patients. That's our job. Particularly in the hospital or in any healthcare setting, you're seen by many different healthcare providers. And because of that, the nurse is kind of like this mediator between all of them, questioning all of them to kind of get them on the same page, the same consensus. The nurse is going to spend more time with you than the doctor. And because of that, the nurse gets to know your normal very, very well. So I want to go through a day in the life of what a nurse does. Unfortunately, I can't bring you through the hospital because that's a violation of HIPAA, but I can talk about what a day-to-day looks like. But I'm going to do it from the patient's point of view and then go behind the scenes. And maybe this could paint a better picture of what it's like to be a nurse. So let's say you, the patient, are having trouble breathing. And you've been coughing the past few days, you're having trouble breathing, and when you cough, nothing's coming up, but you can kind of feel like it's mucusy and you want to cough something up. And you start feeling lightheaded. So you're like, I think I'm going to go to the emergency room. So you go to the emergency room and you're greeted at the front desk by the secretary or unit clerk. They take down your information and then they give it to a nurse. The nurse that they give it to is called a triage nurse. The triage nurse looks at your case and looks at everyone in the waiting room and looks at their cases and says, who do I need to see first? We call this nursing priority. And nursing priority is something you learn in nursing school. Who takes priority over someone else? Sometimes that's a hard decision to make, but it's something that you learn in school and you just put into practice. Priority is super important because it can mean life or death for somebody. So the nurse is the one that makes the decision about who gets seen first in that waiting room. Now, sometimes you think you need to be seen first, but you don't know what another person has. Just because you may be in excruciating pain, there may be someone there who is having a silent heart attack. And so there are certain things that we kind of know how to triage, and so we call that the triage nurse. The triage nurse then invites you into the emergency room. And who are you greeted by in the emergency room? Another nurse. You're greeted by the ER nurse or one of the ER nurses, and they do a nursing assessment. So nurses and doctors have their own assessments. Nursing has a nursing assessment, and doctors have a medical assessment. The nursing assessment is going to involve a well-rounded whole picture approach to what's going on. So they're going to ask questions that are related to what your priority or chief complaint is, and then they're going to kind of do some investigative work. They're going to listen with their stethoscope, and let me just sidetrack here. Nurses use their stethoscope for a lot more than just blood pressures. I would say I use my stethoscope the least for blood pressures. I'm listening to people's lungs, hearts, bowel sounds, NG tube placement more than I would blood pressure. Is manual blood pressure important? Absolutely. But we use our stethoscopes for a lot. And we end up reporting what we hear in our stethoscopes to the doctor. So nurses learn different lung sounds, different heart sounds. I can tell you what are rhonchi, what are rales, what is wheezing, what is pleural friction rub, what is S1, S2, S3. These are all types of sounds that if you're in the healthcare profession, excuse me, you know what I'm talking about. So the nurse does their assessment, and then the doctor is going to come in after talking with the nurse. And the doctor is going to do a medical assessment and order labs. Maybe he'll order an x-ray because you're having trouble breathing. Let's rule out pneumonia, the doctor says. The nurse is going to look at this and say, all right, this person's having trouble breathing. The doctor is thinking it's pneumonia. All I know is that this person is having trouble breathing. So what are my nursing interventions? And the doctor is going to do their interventions as well. Nursing interventions for pneumonia could be raising the head of the bed into a semi-Fowler's or high Fowler's position. In fact, nurses are specifically trained on different bed positions. During COVID, we did the prone position for many patients, and we still do to this day. Sometimes we will do something called reverse Transdellenberg. So these are all different things that we do with the bed. We will also increase fluid intake if it's permissible. We also will encourage incentive spirometers. We also will auscultate lung sounds to observe for any changes. We will ask the doctor to prescribe certain medications if we don't see them listed. For example, hey doc, I noticed that you prescribed an antibiotic. This person is having rhonchi but is having unproductive cough. Would you like to prescribe an agent to expectorate all of this mucus? Why, yes, Nurse Chris, I would. I'm putting it in now. So the relationship is together. Doctors and nurses are not separate. We work together. Nurses have a specific goal. Doctors have a specific goal, and they meet in the middle. And we talk with doctors all the time. We check each other. Just the other day, I called the doctor to ask about potassium because he ordered potassium. And the reason I asked him was because potassium was ordered by a different doctor. And did he see that there was a previous potassium order? So nurses are kind of the gatekeeper to make sure that the patient is getting the right medications at the right time, the right treatments. So this person has pneumonia. You have pneumonia. They say, you know what, it's really bad. We want you to stay in observation in the hospital just so we can see how you're doing because you need oxygen. So they send you up to the observation floor or the medical surgical floor, which is where I work. And then you're greeted by another nurse. And the nurse is going to do a admission assessment onto the floor. We're going to look at your skin, see if there's any impaired skin. We're going to listen to your heart, your lungs, your bowel sounds. We're going to look inside your mouth, inside your nose, your ears. We're going to look at your eyes. We're going to feel your body. When a nurse feels you, we're feeling for things. Are there any enlarged lymph nodes that we can feel? Is there any abnormal growths on the arms or the legs? Is there anything that we see on the legs that are not normal? Are veins looking enlarged and prominent? How are pedal pulses? Nurses love feet. Not really, but we love touching feet. I can touch your feet and tell you if there's something wrong. I can tell you if you have a vascular issue. I can look at your legs and tell you, do you have an arterial issue? Something wrong with your veins? Is there something wrong with just your peripheral vascular system in general? Do you have diabetes? I mean, these are all things we can look at someone's feet. We can see a lot at someone's feet, and that's why we touch them. You'll see us touch the top of the foot, and we're feeling for a pulse there to see how your vascular system is doing. So we're doing this full nursing assessment. And then I say, hey, all right, let me look at the orders. I look at the orders and I say, okay, so the doctor wants to administer Zosyn, which is an antibiotic, IV. They're going to give Tylenol for fever, and that Tylenol is going to be IV. They're going to be administering, I see normal saline because they want to increase fluids. Increasing fluids while you're sick decreases the thickness of mucus. It helps to get rid of it. I'm going to be listening to lung sounds. I'm going to be administering these medications. I'm going to be talking with the patient. When the patient is in that room, I'm already thinking about discharge. I'm already thinking, what am I going to do to prevent this patient from coming back? So the patient's on the floor, you're on the floor with pneumonia, and I get called to a meeting. This meeting is with a doctor, it's with your case manager, and it's also with the director of the floor. And we meet to discuss discharge. How are we going to keep, even though you just got there, we're talking about discharge. How do we keep you from coming back? And what are we going to put in place to get you out? We want you out of the hospital. We do not want you in the hospital. And for those of you who feel it's good to go to the hospital, it is good when you need it. But you do have people that abuse it. And what ends up happening is you are at higher risk for getting sick if you stay in a hospital too long. So we want to prevent you from getting sick. So we want you to get out once you are healthy enough. Now, we will never force you out when you're not ready, but we know when you're ready. And it's important that we talk about it, the nurse and the patient. So the doctor, the nurse, the managers, we all talk in this meeting about discharge. From there, at the discharge meeting, we raise concerns. Hey guys, I just want to let you know, my patient, they have pneumonia, and I'm noticing that they are having shortness of breath upon exertion, and they're very weak. Should we order physical therapy for them? Yeah, we should order physical therapy. Okay, great. I'm also noticing that they've been having difficulty swallowing. Should we order a swallow eval? Yeah, we should order a swallow eval. And they told me in confidence that they are having issues financially. Perhaps we can talk about financial assistance for this person. All right, we'll get social services on board. So all of these things are things we discuss in meetings, and the nurse is the driver of all of this. So it looks like when you go to a hospital floor, a nurse is behind a med cart. The craziest times for me to pass meds are from like 8 o'clock to 10 o'clock. After that, med pass isn't that bad, and that's when kind of all these interventions take place. I highly encourage people to get a nursing degree if they want to help people. I'm going to talk about experiences in nursing. I just kind of wanted to break it down. Something else, just a little fun fact. Your registered nurse, when you go to the hospital, let's say you have pneumonia, that registered nurse is also going to give you a diagnosis. You're going to get a nursing diagnosis. In fact, you're going to get several. So every nurse that meets with you is going to give you a nursing diagnosis. So let's say it's day 3, you're in the hospital for pneumonia. So I'm going to go, now typically this is all computerized now, but let me find it in my little nursing diagnosis book. I can name some off the top of my head. So let's say I'm the first nurse you have that day. My nursing diagnosis for you, I noticed that your chest expansion is not symmetrical. So I'm going to put ineffective breathing pattern. Then the next nurse comes on and says, hey, Chris, and they do this through the computer. I noticed today that this person, their oxygen level is 80. Okay, so I'm going to give that person ineffective gas exchange. Hey, Chris, I noticed that this person has diabetes and they're not managing their blood sugar very well. Okay, I'm going to put a nursing diagnosis as ineffective healthcare maintenance. So all of these diagnoses, we as nurses use, these are nursing diagnoses, to put interventions in place. We call it the care plan process. So nursing has their process, doctors have their process, but they merge. So for pneumonia, I'm going to raise the head of the bed. I'm going to put oxygen on you as ordered. We could do chest physiotherapy. We can encourage and teach the incentive spirometer. I always say that word wrong. We also are going to increase fluid intake if permissible. And then the doctor's going to order antibiotics, chest x-ray, fluids, IV fluids, medications, and these two things work together. So nursing is really important. This is the reason why nurses get paid so much. A lot of people think nursing, again, is just blood pressures and med pass, and that is the furthest thing from the truth. And I want you to know, the next time you see a nurse, thank them, because they're the reason you're getting out of the hospital. Doctors play a crucial role, and I don't want people to think nurses are better than doctors, because they're not, but they are equal. We learn totally different things in our schooling. Nurses can go on to become a nurse practitioner and prescribe meds. They still have that nursing heart and nursing advocacy spirit, but they have the ability to make a medical diagnosis and a nursing diagnosis, where nurses can only make a nursing diagnosis. Just a quick side note as well, for those of you who are curious, and we could talk about this more another day, but the difference between a nurse practitioner and a physician assistant. Nurse practitioners are licensed through the Board of Nursing. Physician assistants are licensed through the Board of Physicians, the Physician Board. The biggest difference is a physician assistant cannot practice without being under the license of a medical doctor. A nurse practitioner does not need to be under a medical doctor. Meaning, if I'm a physician assistant, I cannot prescribe my medications if I do not have a doctor on call. Particularly, most places require the doctor to be in the building. So it's a very strict practice, but physician assistants have more ability to be flexible, meaning they can go into any practice they want. Where nurse practitioners, though they don't need direct medical doctor oversight, they are limited in the practice they do. So if I become a nurse practitioner in family medicine, I cannot become a nurse practitioner in acute care in a hospital. I cannot become a nurse practitioner. I cannot become a midwife. That would require additional schooling. I cannot become a psych nurse practitioner. That would require additional schooling. So nurse practitioners and physician assistants, there's pros and cons to each. But nurse practitioners have more independence than a physician assistant. Physician assistants can do a lot as well. So we could talk about this another day. I do plan to have a video with a physician assistant so we can talk about the differences. But this was just kind of a quick video, 16 minutes long. But hey, what do nurses do? I hope this kind of clarified some things. And just to let you know, when you get discharged from the hospital, a nurse will call you to see how you're doing, because we don't want you coming back. We want you to stay healthy. We want to make sure you're going to your doctor appointments. So nurses are your advocate. So realize when you go to the emergency room, realize when you're in the hospital and you're not being called right away, there's probably someone in there that needs more help than you. And I know sometimes when we're in pain, we kind of become self-focused, but just know that these nurses that do triage have gone through excruciating training to know who deserves, I shouldn't say who deserves, but who should be seen first, who should be second, who should be seen third. And the last thing I want to say is you have a right to fight. So if you don't agree with the care that's being provided, you can always speak to patient experience at the hospital, and they usually can meet with you and listen to your concerns and see if there's something else that could happen. I hope this answered some questions. Feel free to reach out if you're interested in nursing. If you want to go to nursing school and you already have a degree, you can. There are night programs for those of us who work. That's what I did. I had my bachelor's and I went back at night to get my RN. And believe it or not, I am finishing up my first year of my master's of nursing to become a nurse educator, but that's a whole nother story. So have a good day. Thank a nurse. And if you want to become a nurse, I highly suggest it.